Good morning, everyone. Thank you for joining us this morning, and especially all those out on Zoom. It is a really exciting event today. Today is our annual Department of Research Research Symposium, and it is the 13th Annual Research Symposium. Today we have the great privilege of Dr. Carla Pugh joining us to present on precision learning with digital and wearable technologies. Are we there yet? By way of introduction, Dr. Pugh is the Thomas Crummell Professor of Surgery with tenure at Stanford. She's the director of the Technology-Enabled Clinical Improvement Center. Her clinical area of expertise is acute care surgery, and her research involves the use of advanced engineering technologies and artificial intelligence to develop new approaches for assessing and defining mastery in clinical procedural skills. So something that we're all challenged with from a trainee assessment. She has been a pioneer in research on telemedicine in her past, and she's a leading international expert on the use of sensors and motion tracking technologies for clinical performance measurement. And I view Dr. Pugh as a thought leader on incorporation of artificial intelligence into surgical care and workflow. By way of introduction, Dr. Pugh obtained her undergraduate degree in neurobiology at the University of California in Berkeley, her medical degree at Howard University School of Medicine. She performed her general surgery residency at Howard and then obtained a PhD in education from Stanford. She started her clinical career with Kaiser Permanente in Northern California and then Northwestern University, followed by the University of Wisconsin, and then has been at Stanford as a professor since 2018. Dr. Pugh has held over 50 grants, garnering over $30 million in funding. She holds multiple patents on the use of sensor and data acquisition technology to measure and characterize hands-on clinical skills. She's a member and holds or has held leadership roles in all of the major surgical societies, including the past president for the Society of Black Academic Surgeons, and recently was a council member of the American Board of Surgery. She's received numerous awards, including the Presidential Early Career Award for Scientists in Engineering, presented to her at the White House by President Barack Obama in 2011. She serves on several editorial boards, has many other accolades too long to review in her 100-page CV. Her goal is to forge new paths towards applied quality metrics in healthcare and to change the face of medical and surgical education through data analytics, data visualization, and performance feedback. Now, after Dr. Pugh's presentation, we will have our residents present for about 2 hours, presenting their research projects over the past year. And following that, Dr. Pugh has a full day of meeting with faculty, and so we're really excited for her to join us. Please join me in welcoming Dr. Pugh.
Thanks, Dr. McGuinn, for that amazing, very kind introduction. I am so excited to be here. I really appreciate the invitation, and I look forward to the questions that you may have. So I do have a few disclosures, as you see here. I think most important is that I did have consulting and royalty fees from CAE Healthcare for a sensor-enabled simulator that I developed when I was a grad student. And but I never accepted research dollars to evaluate the simulations. And I will talk a little bit about some of that work. The agenda is 3 parts. I will talk about wearable technology and some of the data insights that we've gleaned over the years. And I will talk about the Surgical Metrics Project, which is a relationship that we have with the American College of Surgeons, and for introducing the wearable technology to the surgical profession. And I'll talk about future opportunities for digital data. So how many of you measure your sleep, your golf swing, your steps? About 50% in the room and growing. This is, sort of a thing that's been called the quantified self, where people are interested in their own data and using it to hack their lives. And we sort of modeled that with the quantified surgeon in my research lab. And lately, collecting 4 data streams: audio, video, EEG, and motion tracking. And I will walk you through some of this technology and the data insights that we've learned, as well as our work in terms of translating this to the operating room. One of the first studies we did was just looking at audio. And it turns out that you can tell how someone will address an unexpected event in the operating room or during a procedure based on how they talk. And how does this work? So we did a small study with a group of residents doing a laparoscopic ventral hernia repair. And when you look at, this was before deep learning and ambient listening and AI. So we did this with another technology for discourse analysis. And it turned out that the residents that did forward thinking in terms of operative management and coordinating their team members, they had a higher hernia completion score. They were able to address their own mistakes, gather help from others, and they were independent in addressing it and announcing what they were doing. Whereas residents who were more focused on getting assistance with the planning, and you could just tell that just from how they talk and the words that they use, very simple. So I'm going to do this, or should we do this? Little differences, and definitely makes a difference. And so the future of this is obviously ambient listening in the operating room or in the clinics, and pros and cons on both sides. Love to hear the questions relating to this. I've seen some ups and downs relating to the implementation. With respect to video, we've done a fair amount of work. One of them was with a company. A number of different people are using some of the companies that capture video data from the OR and use AI to glean insights. And one of the companies had a pretty sizable database, and they use of laparoscopic cholecystectomies, and they rated them in terms of disease severity using the Parkland scale. And they were trying to convince my team and I at Stanford, this is really great technology. And we were skeptical. And I was like, well, let's investigate. So you've got a database that shows whether someone got the critical view of safety, and you're using AI to determine that. And what I suspect, at least in terms of my hypothesis, is that as the anatomy gets more complex and more difficult, getting to your 5s, 4s, and 5s in your Parkland scale, the AI is going to be inaccurate. And so we had the surgeons at Stanford who do laparoscopic cholecystectomy review in their database, and then they stated for each of the cases whether the critical view of safety was achieved or not. Turns out when we looked at the comparison between what AI said and what the surgeon said, we were actually wrong, meaning where there was disagreement was not on the difficult gallbladders, because if you see this one is pretty inflamed. It turns out that when you have a difficult gallbladder, the surgeons work harder to skeletonize the tissues, and so you can clearly see a beautiful critical view of safety. But when it's an easy case, we actually take shortcuts and you leave a little bit of fat. And this is one of the examples where AI said the critical view of safety wasn't achieved, but the surgeon said it was. And so it really depends on how you train your algorithms, but also, what are those requirements for the surgeon versus AI? So this was one of the things we realized, it's the other direction. Second part of this study, what we learned from looking at this database was and this is the company theater. There's a few hospitals that are using their technology. Having auto segmentation of all of the videos enabled us to look at the moment right before the cystic duct structures were clipped, instead of looking at the entire video. And for the surgeons at Stanford and I, when we looked through this was the biggest benefit for us. We were able to review 50 videos in an hour. And it's something that you just never do, right? Nobody looks at videos much, but when you do, like you're looking at it with a resident. But it was so interesting to see all of the variations in anatomy. And in those moments where you actually can't achieve the critical view of safety as defined because anatomy doesn't allow you to. And now you're off the beaten path. And what an amazing learning tool to see all of the variety of anatomy and the decisions that surgeons made at that point in time to address that. That was an amazing learning opportunity. Still working to have, these companies really implement this for learning and training for, a variety of surgical procedures. But this was the biggest benefit. A lot of work has been done looking at video and object detection. This is some of the older research and work. Now everything's sort of moved towards deep learning. And this was just interesting when Sam too, hit the scene and was trained on 1 billion annotated images. This is all just progressed. This is old news right now. And because these, large companies have so much data, they still are lacking the same volume of surgical data because, they still take the surgical videos from Google and, build these algorithms, but they don't have it at the level that we need it for our workflow. So there's still a lot of work to do, but automatically it can identify people, dogs, random things in videos, as well as surgical instruments. But bleeding and complex tumors, still a ways to go. The real desire is to use AI really to get the short highlight reels. You want that 5 minutes of when there was a critical decision. Nobody wants to watch a 30-minute video or 4-hour video of an operation. You want the highlight reels. So more work to be done there. Moving on to EEG. This is me wearing one of the EEG sensors in the operating room. And I love this picture because when I talk to give, some of the research talks, everyone's like, well, what is it like to wear this EEG sensor? Is it heavy? Is it annoying? And I forget that I was wearing it and I wore it all day. And everybody thought I had a fever because they thought it was a temperature sensor. So I was going to the cafeteria and they're like, oh my God, are you sick? I'm like, no, I'm doing a study. And this is another form factor of that sensor, a different company, headband style. Some people like it, some prefer the foam sticky sensor. So it's just interesting. There are a lot of companies out there that are building these type of sensors. None of them are made for surgeons. So we had to do some work in terms of changing the algorithm such that it fits our brain. They're looking at meditation or gaming, and we're like, no, this is the high performing, highly educated brain, very different than the diseased or meditating brain. But it's just been fun looking at this data, and we've got some pretty interesting insights. This is my brain during an appendectomy. And when we went back and looked at the videos, because it's time series data, so we synchronize it with the laparoscopic video, doing some work with getting open surgical video, lots of technical things there. I won't go into it, but laparoscopic and robotic surgery is easy to capture this. And what you notice is the light areas are when you have sort of lower levels of focus and engagement. The darker areas are higher levels of engagement and focus. And it turns out this aligns when you have visualization of anatomical structures, so the appendix, the mesentery, and then this area here is when you're making a critical decision. I mean, this is the no point of return. You're firing the staple across the base of the appendix and the mesentery. Then you put it in the bag. Not really much to sort of focus on here. And then this is hemostasis before you close. Similar pattern with a lap chole. You get in, you look at the gallbladder, you're like, okay, this is what I'm working with, talking to the resident, coaching them. And even when I'm not operating, if I'm focused on the anatomy, these are the same things that happen in terms of the dark areas, getting the critical view of safety, clipping the artery, doing some more dissection, then clipping the duct, bagging the gallbladder, then hemostasis on the liver, a little more intense than with the appy. And you start to see it actually can tell the difference between level of complexity of an operative procedure. And this is not something we all give it verbally, but now we can actually get objective digital data. This is a real-time view of the EEG data in a sim environment, the two second-year residents, putting some mesh. This is the external view of the camera. This is the internal view of a laparoscopic ventral hernia repair simulator, and it has a Swiss cheese defect in the midline. And so mesh preparation, and you're going to see synchronized EEG video with this procedure. The segment here in terms of focus is when the residents are working together and she's doing a lot of talking and saying, turn the mesh this way. And there's multitasking, you're suturing, you're trying not to stick the assistant, and you're focusing the mesh. And as soon as the surgeon puts the mesh in the abdomen, the brainwaves change. And at that point, they're working on their own. They're no longer talking. And I'll stop talking and show you the video. Suturing, talking, coordinating. This is all the multitasking we do in the operating room when we're doing teamwork. And as soon as you see the mesh appear down there, the brainwaves change. So just because of this time series data, and now there's motor control and planning here, so the brainwaves go back up. What I noticed later was that we do celebrate our wins. This is when they're visualizing, making progress and getting those transfascial sutures in. And so this is, if you think about synchronizing this with video, this is a biomarker of the critical moments. And the critical moments for a junior resident will be very different than the critical moments for an experienced surgeon. So opportunities for learning, segmenting the data without having human annotation, which is really what's the backbone of some of the AI algorithms. After wearing the sensor on my head, a number of times the OR nurses wanted in on the game. And so we did one time when we put the sensors on the circulator and the scrub nurse, and this was just interesting to see. So you could tell when the third year resident gets in and they put the drapes on, brain waves go up. Then there's the timeout with the circulator who leads the timeout. This is abdominal entry. And again, there's visual loading. When you see something more complex, or, other than looking at drapes and people, your brainwaves tune in automatically. Interesting, the scrub nurse here, I didn't label them, but they're in green. The scrub nurse had some peak in their cognitive focus when there was abdominal entry. Sorry. Then you get to this part, clips on the cystic artery and duct. This is the scrub nurse you want, who's with you. If they're not paying attention and looking away, their brain waves are going to stay low. And guess who's leading the instrument count? Both the circulator and the scrub tech. This is just interesting that you can actually map the course of care with EEG focus of the team members in the room. So talking about team coordination, opportunities for training scrub techs, when they're with you, when they're not. A longer operation, you can tell these fluctuations. So lots of fun here with this data. Now I'll move on to motion tracking. These are, you could see under the glove here, this is a wired system. There's lots of different motion tracking systems, and we've explored all of them over the past 20 years. There's two of them that we're using, a wireless one because we want to get in the OR. This one is a wired system, and it's electromagnetic motion tracking. And the benefit of this compared to the LED is that you don't lose line of sight. That is one of the biggest issues with being able to collect data in terms of what we do in the operating room. The in-light camera is obstructed by views with your head in the way, so you need a camera on the surgeon's face if you're really going to get what we're doing. The LED motion tracking depends on a camera capturing the light, so it's the same obstructive view. So the magnetic motion tracking, you don't lose any data. So this is really the ground truth for motion tracking. And right here, what you'll see is it's not novice, not tying. It's actually a fellow, but they make some mistakes. And I'm just going to show you the videos. The fellow makes a mistake from an efficiency standpoint up front. One, you can see they are sewing away from themselves in the beginning. And then this is under the microscope. They pull their suture tail out really far outside of the microscope view. And then they spend the rest of the time chasing that long suture tail. Little bit of a tremor as well. You can see it. But they're pulling that both suture tails out of the view. I'm going to start the experience surgeon. Number of things here, and I'll talk about it as you're watching. Only one suture goes out far, then you have a shorter tail that you're tying to. And you see the difference in the working volume. The stitch for the fellow is actually good, but think about trying to give this fellow some feedback, verbal feedback on how they could be more efficient. They're not going to be able to hear you because, like, look, it's a great stitch. What are you complaining about? And then you show them this. This is your movement. This is the movement of the experienced clinician. And so this is in terms of percent completion. And so the blue is when you're just beginning. And this is the first knot tie. And as the suture gets smaller, your working volume gets smaller. It's focused, like it just captures everything that you're doing. And here you can see the trimmer and you see still this working volume because of that suture tail. This is not technical skill. This is not technical skill. This is a rule-based error. And so this fellow knows how to suture and tie. But the next level of things that help you become efficient and safe is really knowing some of the rules. And of course, we're tired. Sometimes we tie and forget. Experienced surgeons don't accept inferior circumstances. So if you're tired and you pull out the suture tail long, we tend to cut it, pull it out, and then keep going so that we can be efficient. The other thing is experienced surgeons move slower when it counts. And that's how we finish faster. Something to think about there. Another example of the motion data, full procedure, laparoscopic ventral hernia. This is a simulator. And we had residents do a ventral hernia repair. And then we took the skin off the simulator and then graded their hernia repair according to sort of the SAGES guidelines. So it gave them a scale of 24. After we did this study with 97 residents from different programs, we just cherry picked to see what the motion data would look like for a top performer versus one who got a lower score on their hernia repair. And this is the motion sequence for a laparoscopic ventral hernia repair. This is where the surgeon is standing, the patient is here, hernia site here, and the Mayo stand here. And so you see a lot of movement back and forth from between the surgeon and the hernia site. This is the motion pattern of the person who got a lower score. And the first thing you see is the working volume is very different, a lot more movement here, but all of this movement back and forth between the Mayo stand and the patient. And if you're doing that during the laparoscopic procedure, you know something's wrong. We looked at this area because it was so bizarre, and it turned out that this resident made their incision for the port site too large. And every time they then made some major movements, the port would come out. So they'd have to take the port out, take their instrument out, put it on the Mayo stand, get the introducer, put it back in. And they did that several times before realizing, I could just actually suture this smaller so that it doesn't come up. But it was too late because they had a fixed time. But this was the motion pattern, and you could see how some of the errors and this is another, it's a rule-based thing in terms of the incision size. So motion data can also not only look at technical skills, but surgical workflow and planning. And sorry, I'm realizing I'm pretty far away from the microphone. One of the other things we learned about motion tracking, even with a basic suture board, we had the suture board that we called it perception. We had people suture on balloon material, tissue paper, and foam. And this was part of a larger study that we did with second-year residents going into the lab. And we just took the data from all of these 7 different stations and put it in a database. And one of the things that popped up that was unexpected was that the motion on the suture board correlated with motion for a laparoscopic ventral hernia repair. Made no sense to us. We also noted that it correlated with bowel repair. Makes a little more sense if you're suturing the bowel. When we looked at it in depth, it turns out bimanual dexterity, which is, do you assist yourself? And that's one of the things that you learn when you're between second and third year. Some people take a little longer to learn how to assist themselves. And then working volume is the same thing I showed you with the others. It's really sort of planning strategy and situation awareness. And one of the things someone noticed is that when we were doing this with medical students and they're suturing, everybody pulls their head back because they are just a large working volume. And so situation awareness then gets you focused with your planning. But that's why there's a correlation between just general suture board skills and more complex procedures. Just sort of in summary, with respect to motion data, it definitely has value in skill assessment. And not only when you're moving matters, but it turns out when you're not moving matters, because that's the choreography of the entire procedure. And so when you're not moving, or when you're moving more slowly, that's when you're doing information processing. You're getting information from the tissues. You are adjusting in terms of how the tissues respond to you, and you're doing surgical planning and communicating with your team. And so what we call it idle time definitely matters as well. The one that we did with the laparoscopic ventral hernia, it turns out we could tell within 5 minutes of that motion data what the outcome of the ventral hernia repair was going to be. So we called it, just a 5-minute assessment. And this is just another map of the sensor data, looking at how the difference between those who are practice ready and those who are not, according to the simple app rating. And there's major differences. And so we can actually be very specific in terms of identifying persons that need help, focus training with bimanual dexterity, depth perception, picking out that individualized specific thing that's going to help you get to the next level of skill much more efficiently. We also put some of our motion metrics into a machine learning model with it was a database where we had surgeons having the motion tracking technology, and we had trained coaches use the simple app. And this was the first time that we had simple app ratings on practicing clinicians as well as residents in one study. And it turns out the principal component one was the motion metric, and component two was the simple app rating in terms of whether you're practice ready or not. And it turns out that the motion metrics can predict the simple app rating with 82% accuracy. So we're getting closer to being able to have automated, metrics that would then give you specific feedback in terms of, what you need to do to shorten the learning curve to competency or to mastery now that we have the data. So advances in AI from this perspective in the motion data, it's been really fun partnering with my engineering colleagues. Many of you have seen some of this, where you can really use deep learning to understand movement. And this is really, really exciting because for me, I'm all about hardware reduction. If I can get rid of the motion tracking, then it makes it so much easier. This is looking at motion of fingers. This is called pose estimation. And these are all new deep learning techniques that can help you get this data. The difficulty still comes back with line of sight. This is beautiful data when you have a camera focused at your hand. Our hands are in an abdomen or, in the operative field. And so line of sight really makes the ability to use this less accurate. What we're hoping to do is to combine now with our motion tracking data plus this video analysis. We can actually, our dream goal, if we can get the funding, is you can get synthetic data, because you can now predict if you only have maybe 50% of the hand movements from this video and deep learning. But if you have a larger data set from the motion to get the full data, then you can predict what the next movement would be, even if you lost line of sight. I know I'm getting real kind of technical here, but this is exciting that we could potentially get here. So coming soon at a theater near you. Surgical Metrics Project. We started this in 2019 when David Hoyt was the executive director of the American College of Surgeons, and he was definitely pro data. And he partnered with us and gave us some exhibit space at the Clinical Congress. And we, promoted this as having surgeons learning about this technology and digital data. And it was very interesting. There were a lot of people who came, early adopters, obviously, and they wanted to sign up. There were also a number of people who came who did not participate, but came to warn us that we were treading uncharted territory, and that there was a risk of us losing control of the data that was going to be used against us. And I listened to those people because that, if you think about the balance between, all of the fun and research with data, there is always, when we look at the medical field, we are really using assessment as high stakes, and the measurement culture in medicine is very different than sports. And it's punitive. And so there should be fear, and we should plan around that, in terms of what it means, whether it's lobbying to Congress for our ability to use this data and it not be discoverable. Most of this data is protected if you're a patient safety organization, but that's at the state level, that's at the federal level. State level laws differ widely. And so, trying to keep this type of data such that it's not discoverable is actually real work that has to be done. This was the setup. We had 10 simulated operating rooms and or our station set up. In here is the surgeon. This is the surgical assistant. And these persons we told them the scenario was that you had just finished a 2-hour lysis of adhesions, and you're now running the bowel looking for enterotomies. We didn't tell them whether there were enterotomies, how many there were, or where they were. They just got 2 feet of bowel, and we had engineered with the standardized fashion to make 2 holes in the bowel. And I'll show you what we found. And this was practicing clinicians. Most of my data, I collect data from practicing clinicians, because if we build a database of practicing clinicians, then that enables us to use the data to help residents and fellows. So this was really our goal. We also had retired surgeons participate, because that was one of the questions, what does it mean? If you have questions about that, it's very interesting data. We can talk about it. So this was the operative task. We created 2 injuries next to each other, one really small and a larger one. And we really wanted to force a decision. We wanted to understand whether people repair these 2 independently, or whether they cut the tissue in between and do a single repair. This is what the bowel looked like. And so when we went through the video analysis, we had 255 participants. We lost some data because this was the first time we did the assistants that you saw, the surgical assistants, were admins from the Department of Surgery. This was the first time we did this big exhibit. And turns out even one of the new researchers that we trained hit save, but wasn't putting in the participant numbers. And so we lost data at one entire station over 3 days. So the other one that we excluded, when we wanted to look at those who purposefully repaired both of the injuries. So those who missed one of the injuries, didn't see it and didn't repair it, and they leaked, that's a different failure mode. So we excluded those in this analysis. So there were 148 surgeons in the database that found both injuries. Only 28 of them cut the tissue in between and repaired them together. But when we did the standardized leak test with the standard volume and a standard force of fluid into the bowel, there was a significant difference in the leak rate. And we look at those who repaired each of them individually, there were some who did a single layer, some who did a double layer, and those who did a double layer had a significant difference in the leak rate. Turns out if you did a single layer, it didn't really matter whether you did interrupted or running. However, if you did interrupted and you didn't put a corner stitch, you had a 50% leak rate. So I have to be fair and pause here. This is the leak rate that we do on the table, where you squeeze the bowel before you close. And so this is not post-operative leak and return to the OR for a sick patient. We didn't allow them, to squeeze and do a repair because we wanted to get a larger volume of surgeons relating to the decision-making. But I will say that there were some 1-stitch leaks and there were some 3-stitch leaks. So there is some difference here. I think the question for us is, who are these people that are on the riskiest pathway and they still don't leak? What do they do differently? And this is the corner stitch. So the people who don't do this corner stitch have a 50% leak rate. Those who didn't leak, they put in almost 1.5 times suture in that 2 centimeter rent in the bow than others. And they had greater bimanual dexterity in terms of assisting themselves. Doesn't really make sense, but I will tell you bimanual dexterity shows up in terms of a mastery metric throughout a number of our procedures. So, and I'll show you one with robotic surgery. It's platform agnostic. It really has to do with situation awareness and planning. And I think those persons have less cognitive load and then have more resources to pay attention to tissue type and other things, and they have room for decision making. But this was, what's your requirement for a 2 centimeter rent in a bow? And these are sort of untested technical decisions. This is not technical skill. Everybody knew how to sew. It's a technical decision. When you look at the bow, the texture, the caliber, and a hole in the bow, how are you doing what you do? And some of it, this is how I do it. So we said that individual preferences can be quantified, and in this study were shown to have measurable effects on procedural outcomes. Second project at the Clinical Congress 2024. So this is 5 years later. Surgeons, we didn't have any surgeons come to warn us. We did this every year. Obviously, the Clinical Congress didn't exist for 2020 and 2021 because of COVID. But we did 2022, 2023, 24, 25, and we'll be back again for 2026. But I wanted to show this study, and it was interesting. When we were here at the college, more people came to us now having the realization of deep learning, agentic AI, all of these things happening, and the realization that Intuitive and all of the other newer robotic companies are building in data collection into the robot. So now when they came to our station and looked at the technology and what we were doing, they were all saying they were happy that we were doing this, because surgeons need to be the ones in control of this data and dictating how we use it and what it means and what's useful for us. Think of industry developing decision support for us when they don't really understand our decisions. Lots of work to do, lots of opportunities. At this surgical metrics, and every year we do a different procedure. This one, we actually had Medtronic with their new robot, Hugo, and we had Intuitive there with their new DV5 robot. And we had to put them in opposite corners so that there was no fighting or competition. But we had a paid study with Medtronic. And what we did was have persons that had high robotic experience or low to no robotic experience come. They had a pre-assessment within their domain. So those that were robotic surgeons did a pre-assessment on a VR robot with the fundamentals of robotic surgery. And those that were laparoscopic surgeons mainly, or had early robotic experience, did the fundamentals of laparoscopic surgery. And all of them wore the EEG, the motion technology. And these are, if you're not familiar with the fundamentals of robotic surgery, there are 4 tasks in terms of four-thumb cutting, ring tower transfer, knot tying, railroad suture, and puzzle piece dissection. And on Hugo, we had a time cutoff, but you can see the number of surgeons that were able to complete the task decreased as the time went on. So most of the data I will show you focuses on these top 3 components. And it turns out just with the first task, the fourth-arm cutting, there was a significant difference in duration, like we usually expect, between those who are in the lower numbers of prior robotic experience versus those that had high. And then this angular velocity of the left hand. We look back, all of the surgeons in this study, except for one, were right-handed. So if you have a lot of velocity in your left hand, what does that mean? Bimanual dexterity. You're using both of your hands in planning. So we wanted to take all of the participants and map them out and see what is this angular velocity. And so if you look at those that are in red, the average of their angular velocity is here. It's sort of like 0.05 in this area. Those that are high skill are in this area, near 0.2. too. And so there's a group of people that are well above the average of the robotic surgeons. And there are a few that are above laparoscopic, but there's a lot that are below in terms of their bimanual dexterity. So I wanted to see, how does this relate to the duration? And I took those that were above average. And it turns out some of the laparoscopic surgeons had amazing bimanual dexterity, and that transferred to the robot, a robot that they had never used before, with Hugo. And this was before FDA approval. So none of these, all of these, the robotic surgeons in this study were all Da Vinci surgeons going to Hugo for the first time, and then the laparoscopic surgeons going to Hugo. So we mapped those persons, and it turns out the green circles here, all of those who had this high bimanual dexterity on the duration ended up being the fastest, which is what you expect. There was only one person who was not. They had other issues, and this was someone who was FLS. This means that they actually have a higher situation awareness learning need in terms of transferring their skills to this robot, this particular platform. But everybody else were in a different, in terms of super efficient and then super slow. Here's the other one. We looked at those who had the lowest bimanual dexterity and mapped them to this. This is what affects. So if you talk about someone who's like slow on the robot, it's not because, how do you differentiate between learning the robot, or are there skills deficits that you're bringing with you to the robot that actually will slow you down? In addition, so this helped us to understand the multi-layer complexity of how you get someone to efficiency on a new robot. And some of it is the robot platform, as we've seen. Some of it is really your surgical skill that you're bringing with you, and what's needed. This person was someone who actually ended up being super efficient, but had low bimanual. And this is someone who, these are interesting. This person doesn't need to go to a in-depth full day Medtronic Hugo course, because this is a fast learner. This is someone who has amazing situation awareness, and they can learn it really quickly. So you can tell that mastery has different components. You can be a master at situation awareness, but still need help maybe with bimanual dexterity, and the other way around. So it's just interesting that it's more complex than we think. It's not just either you have technical skill or you don't. There's multiple layers. We looked at, then there was a correlation between low bimanual dexterity and those who finish more of the Hugo task. And it's just for us thinking that not only your anatomical expertise, your open surgical skill, laparoscopic skill, robotic skill, they're all related. And so thinking about how your skills transfer from one platform to another, especially in this era of increasing translation to robot. The fun thing about this is we figured this out for these surgeons in 10 minutes. This is the information we need. And then now you go on to partner with someone or a colleague. And again, we can be very prescriptive in terms of what you need to practice, whether it's depth perception, bimanual dexterity, or the robot situation awareness and the arms, and how to use all of the components of the robot. Again, our report to the companies was that, your one size fits all technical training courses probably need to be changed into something that's more precision learning and focused, where you divide the surgeons according to their needs. And mostly they're doing this based on time of proficiency, time and error metrics. But if you don't know where the error is and how fast someone's going, maybe related to different things, you have to get a little more specific in detail. So practice doesn't make perfect. Actually, practice with precision metrics makes perfect. And that was our point to the companies. So I will be talking now a little bit about future opportunities and come to a close, but think about, what if we had access to continuous data streams in the operating room? Taking all of the best of real life surgeons and building a digital twin of the best of all of us. If you think about it, that is what AI and ChatGPT does right now. It takes the best of our papers, the best of our research, and it puts it all together, and it gives it back to us in 5 minutes. And that is just amazing crowdsourcing. We could do the same with surgical skill and have that benefit our training process. And using this for formative assessment is what's really important. The high stakes assessment makes people not want to participate. It's punitive. Formative, such that we all partner and work together and help each other be the best that we can be. The exciting thing is that we just got funding from the American Medical Association for their precision education program. And so the timing is perfect for us, and we're super excited. Our project is called Center Enabled Precision Learning Curriculum, and we are partnering with the American Board of Surgery and the American Board of Medical Specialties. And it's about data, and it's about AI and tailoring the learner's needs using data and across the continuum. So not only medical students, but fellows, residents, and practicing clinicians. We're bringing in some of our original work when we also had force capture data during physical exams. I didn't talk about that. That was the beginning of my world with sensors. And giving a mock-up dashboard where the boards will have to say what their cutoff score is for certain procedures in terms of competency, but there's always sort of a range of mastery. Partnering with them will help us understand how you translate digital data into the metrics that we need to give people feedback. So there's a collaboration path that we have with our grant for the certification boards to help us understand how to translate that. And the boards are looking at using this for continuing certification credits, not for high stakes. They are looking at, if you participate as a practicing surgeon, that you get continuing professional development credits. Now, everybody always asks, what if you're on the far end of the learning curve and it shows you need improvement? The next level will be giving you more credit for getting coaching or doing peer assessment or meeting with your colleagues to talk about, that one area that you may need improvement. So multiple step process with this grant. We're doing the same with the academic medical centers. Once we understand what they look at for competency for this data, then we can give this to the medical schools and residencies to use this and implement it. And our goal is to get everyone this wearable technology so that those who are interested can use it and start to give more feedback to their students and trainees. So how do we get to precision learning at the point of care? It's with trusted organizations and us working together. And that's really the goal of my work. And this is where we are right now. So thank you.
That was fantastic. Thank you so much for taking us on your journey and then sharing with us where we're going. We're going to open the floor for questions.
Thanks so much for coming to visit us in Aurora and for such a fascinating presentation about what is current and then perhaps soon to come. I have so many questions, but I'm going to limit it so other people have an opportunity, which is intervention. So you have an ability to say, what intervention do we need to do on someone who's a low-skilled individual that's going to make a difference? Because we use a lot of teaching interventions which may not be effective at all. And so now you can determine what actually works to help people improve their skill. So what have you learned in that area?
No, thanks for that question. So what's been fun is using this technology with a variety of simulations and in the OR. The simulations are what matters. If you're going to have someone train, that's likely where they're going to be able to practice is in the simulated environment, whether it's with a cadaver or an animal model or some of the VR or benchtop models. What we've learned is actually which task on each of those models is the best task for depth perception or by manual dexterity. And I'll give an example. When we use a laparoscopic cholecystectomy with at the Surgical Metrics Project with hundreds of surgeons, it turns out laparoscopic cholecystectomy simulation is not the best one to train by manual dexterity. Why? Because most of the time you're holding the gallbladder in one place or moving it. Like you have one hand that's not moving. Its goal is to give you operative exposure while the other hand is moving. There's small parts of it where you're moving both of the tissues, but not as much as, for example, when you are doing laparoscopic suturing. You are assisting yourselves about 70 to 80% of the time during that whole thing. So we actually now have a database of all of the simulations that fit in by manual dexterity, depth perception, all of the different skills that you need. And so it's a library now. We haven't published it, so I didn't show it, but it was just crazy. We weren't expecting to look at it, but we were able to see it in one of our studies that there's a difference in these different trainees. So now we are able to really focus and give someone, yeah, this is the task you need to do. And a lot of it's translatable, as I showed you. Just suturing on a suture board, I can tell how you're going to do with bimanual dexterity in a laparoscopic procedure, or your working volume, your situation awareness. So, and these are 5-minute assessments, and then you go and you do the training with more insight. Thank you.
Dr. Dillon. Yeah, quick question about like scalability, and I guess a little bit like what you were saying, which is, do you see this as something that going to have multiple places, or is this something that if we identify a learner struggling, that potentially we consult and either virtually or even send the person out to get, sort of a boot camp or whatever you want to call it, assessment and intervention as a way to improve technical skills? Because it seems like it would be hard for all of us to replicate this in our own institutions, but we might be able to, preferentially take advantage of it. We find people who are struggling, or that's the feedback, or that's the EPA assessments, etc.
Yeah, thanks for the question. I was dying for that question just because that's the whole goal with the AMA grant. And so in full disclosure, I have a startup company, and we have worked with these technologies, the EEG companies, off the shelf, and the motion tracking technology. And the AMA is helping us to make the sensor packets affordable. And we're working on right now, I have the first version of the software that gives you this feedback in the report in terms of where you land and what training you need. So we just got started with AMA in February. We're a couple of months into it, but that is the entire goal of the AMA, is to be able to get this technology affordable and have everyone have access to it. So coming soon.
Thanks, Dr. Pugh. It was an excellent lecture. How well does an expert teacher, how well can an expert teacher pick up on some of these findings that the computer or AI is picking up on?
So yeah, excellent teachers can pick it up really well. The difficulty is, and that's similar to what I showed with the motion metrics and the simple at rating, those were expert surgeons. Those were surgeons that are coaches for a variety of procedures, and they were picking it up. It's called the global rating. Humans are excellent at it, picking it up. What's difficult for humans is you can see the end effect and give a judgment of certain movements, and that's what you use, but you can't give that detailed report of whether bimanual dexterity or depth perception was your biggest issue in terms of what you need to focus on. And so we give the great ratings, but then the report card and what to do next is where it's difficult, because it's actually difficult for us to track continuously forces, motion, and those types of things. So I think in combination with the technology and an experienced clinician, we can definitely achieve our goals for precision learning.
So to that end, have you developed a reporting system back to the trainee, whatever level they are, that says these are the 10 bullet points, or these are the 2 things that you need to focus on most based on the integration of EEG, voice, video, and motion?
So we just did. I mean, it's not fully built yet, but I have the demo app on my iPhone. This is my Android. What's really exciting for me is that I've been working on this for 20 years. And 10 years ago, when I thought it was time to launch, I got a quote from a company to build the software for me, $500,000 just for the software. 2 weeks ago, now with AI where it is now, someone is doing it for me for free with vibe coding and Claude. Yeah. I mean, so this is, the time is now. We're ready. And so that cuts the cost, that then changes the amount of cost that I would need to charge the schools and boards and folks to use it. So it's exciting.
Other questions for Dr. Pugh?
That's a quick one. You're gathering lots of data on trainees, and you mentioned in your talk the differences at state levels in terms of discoverability. Is that going to affect, certain states are going to be more favorable to introduce programs, or is there going to have to be legislation federally to control this? Because you could see, I would think difficulties as information gets gathered and our colleagues in other fields start to realize that this is available for complications down the road. Do you see that as a difficulty going forward?
5 years ago, I did, when we were first starting to partner with the college and taking a deep dive on all the differences in the laws. Obviously, our government is changing significantly, and there's one part where it's actually a little more pro-tech in terms of doing it. Where we found the sweet spot, and again, these are things you learn when you have a startup company and you're in Silicon Valley and you have lots of people that are much, more entrenched in terms of what does it take to get a technology out there. Because it's wearable technology, this is my wearable, my data. So it fits in a spot where we'll be able to do it in more places than not. Yeah, I mean, people are wearing Whoop bands in the OR. That's your own physiologic data. It's your own performance. And what some of the other companies are doing is making sure that the data is either de-identified if you're pulling it. So working with the boards, they don't want the data. They don't want to be responsible for it because the legal system knows that is one nodal point where they can go and try and summon data. So they don't want the data. They only want the report that you participated in and where you were. And then they check it off and then delete it. So looking at all of those spots where, the data that can actually make us the best that we can be can't be used against us. That's where we're headed with, the trusted organizations, the AMA, the boards, and the college. But it's still not perfect, but my wearable, my data, that's definitely a different space than what other people have with some of the technologies.
That's one last question, Dr. Yang.
Hi. I'm a urologist. I use a lot of big scopes, like that. Wondering any of this probably been tested in endoscopic or things like that.
Yes, we have. We've done with colonoscopy and upper endoscopy. Anything that has a video feed, we can synchronize your EEG and your motion with the video.
Well, Dr. Pugh, thank you so much for joining us. This is a bag of memorabilia from Colorado, including a book on the history of our Department of Surgery and some other Colorado themed things. Thank you so much. We can mail it to you if you need. Is that better?
Thanks, everyone.